All right, so we'll continue today. I'm going to, I sent you the slides. I'm sure you have read through, but even if you have not read, just listen carefully. I will try the best I can to run as fast as possible. Okay, then let's see what happens. So please, today and tomorrow, we'll use it to cover up the remaining part of these lectures. So please, let's go. Oh, sorry. All right, so today we'll be looking at analytical studies, then experimental studies. Look at analytical studies, then experimental studies. Okay, then if we have some time, most likely we will look at the issues of bias and confounding, but I've given them to you. I believe you could have read them or maybe not, I don't know. But please try and read those things. If you read them, I'm explaining now, some of the questions you are asking me would have been taken care of. All right. Analytical studies are the ones, when I was introducing research or the study designs, I had said that descriptive studies use it to respond to questions. It answers the question of who, where, and when. It's a description of who is affected, where the incident took place, and when the incident took place. Analytical studies, on the other hand, is responding or answering to the question of why and how. Why and how. So it's a little bit higher level of evidence compared to descriptive studies. It's higher level of evidence because it seeks to know why things happen, why disease occur, and how it occurred. The earlier one, descriptive, is just explaining who is affected by the disease, when or where. It does not go further to try to find out where or when. Oh, please, some of these calls. 1 minute. Hello. Good evening. Please. Sorry, an important call I couldn't resist came in there. All right, so well, let me now put off my phone. I beg. Let me put it on do not disturb because I don't want anybody to disturb me now. Okay, so as I was saying, the cohort studies is answering to the, responding to the question of why and how. And we started with case control. Case control studies, right? I think we just we did case control studies. Is it not? Or I didn't get to case control studies. Oh, sorry, I forgot that I muted. Can somebody type in for me? Where did we stop? Let me know exactly. Just type in if you remember. Oh. I thought we did case, yeah, stop at case control. Analytical study, case control is part of analytical study, right? Okay. So in case control studies, I told you that in case control studies, okay, to start cohort. So we're in order. All right, so case control studies we did. Case control study is a type of study, just as the name suggested, cases and controls. We start from behind, from the present day cases, then we go back, identify similar controls. So the aim is to look at what factors must have caused the disease. We have the disease at hand. Our objective is to identify what exposures probably led to the disease. What exposures? That's the right word. Probably led. That is why we calculate the odds ratio. Now, the cohort studies are forward-looking as against case control that is looking in the past to identify the probable causes of the exposures. So for cohort studies, they are forward-looking. They are longitudinal. That is from now going forward to see which diseases might occur in terms of cohort studies, right? So for cohort studies, you also have two groups, right? You have two groups. One group is exposed to a factor, an exposure factor. Another group is not exposed to that factor, right? So, but we want to see or find out what diseases could eventually emerge as a result of exposure to that factor. For example, somebody is exposed to inhaling, say, dust from a quarry because probably is not using protective respirators. So if we look at maybe group of workers in a factory, look at maybe a cement factory, two groups of workers. One group are the people at the production line, interacting with the cement dust. The other group, identical characteristics in terms of age, socioeconomic class, and everything. The other group are those working in administration or other aspects that are more indoor with their air conditioners and all that. So we decide to follow these two groups of workers over time, over 30 years or over 25 years, to see if exposure to cement dust will lead to any disease eventually. Then among the group that is exposed to cement dust, we find out of, say, 50 of such workers, or say 100 of such workers, 100, we identified that 10 of them developed, lung cancer or cancer of the pleura. Pleura is the covering of the lungs, the tiny sheet that, covering on the lungs. Such cancer is called mesothelioma. But that's not important for clinicians. Well, okay. Let's say lung cancer. 10 of them on the production line. Then we observe among the people in the administrative section, the secretaries, human resources, they are not directly interacting with the cement and all that. And we discovered that only 1 out of 100 developed lung cancer. So what do? We make some simple calculation. We calculate the relative risk. And the relative risk is simple. It's done with a formula. Incidence of the disease in exposed people over the incidence of the disease in the unexposed people. So the incidence of the disease in the exposed people is 10 over 100, because as I said, of the number of the 100, 10 people develop disease. So incidence of cancer, lung cancer among those in production line is 10 out of 100 we followed for 20 years. Now, so when we say that, when we put it 10 over 100 is 0.1. Now we said the formula is simple. Incidence of the disease in the exposed over the incidence of the disease in the among the unexposed. Now, the unexposed are those in the human resources, admin, secretariat, whatever. Of the 100 we followed, only one developed lung cancer. So we say incidence on the disease among the unexposed is 0.01. That is 1 over 100. So when we apply that formula, incidence of disease over the in the exposed over the incidence of the disease in unexposed, we have 0.1 over 0.01. And what do we have is 10. It means that our relative risk or risk ratio or rate ratio is the same thing. If it is risk, for instance, the risk of developing disease, that's what we call it relative risk, right? Okay. If it is the rate of development of the disease, we can call it rate ratio, because it's a ratio. The disease in the unexposed over the rate in the unexposed over the rate in the exposed, right? That's why we can call it rate ratio. So the relative risk will be 10. Relative risk will be 10. Relative risk being 10 means that the disease is 10 times more likely. In this instance, lung cancer is 10 times more likely to develop among those exposed to, say, cement dust compared to those not exposed to it, right? We did not say that cement dust caused lung cancer. No, we have not said so, because causation is a different thing altogether. Causation. There are certain criteria we will use to talk about causation. And I'm sure when I gave you earlier on in the general epidemiology class, I gave you the Braxton-Hicks classification of causation. That is if you are reading anyway, you remember, but if not, well, that is story. Okay. Now, in identifying the cohorts, as I said earlier on, they are people of identical characteristics. They are well matched. You can match them by group matching or individual matching. For instance, if you have a 45-year-old in the exposed factory line, you identify a 45-year-old in the unexposed. You can do age and sex matching, female for female, male for male, age, socioeconomic status or socioeconomic status, like that, right? So you can match them. If you do individual matching, then, but that is more difficult to do. What is done most commonly is group matching. Group matching can say average age of this group is this, average age of this group is this. like that. That's where group matching. If it is where you are measuring weight and all that, you will say the average weight of this group is the average weight of this group and things like that, right? Average income of this group is this, average income of this group is that. We are using group matching. Okay, so when you have done that, this is exactly everything I explained. I'm sure you have written them, you have seen them in the note. That's why I give you in advance. Disease incidence in the exposed group over the disease incidence in unexposed group, right? That's it. So in this example, our relative risk is 4. So we say that individuals that are exposed are 4 times more likely to develop the disease than those not exposed, right? Then there's something, a concept called attributable risk. Attributable risk gives us the measure of risk associated with the development of that disease that can be ascribed to the disease factor. Take for instance now, there are somebody can be exposed to disease because he contracted cement, for instance, in this case, cement dust. However, it is also possible that that individual has other factors, other internal problems, right? That is not cement, that can make the person develop the disease even faster. So if the person develop the disease, at times we do not ascribe the entire say that the disease was developed entirely because of that exposure factor. It is possible that the person was exposed, quite all right, but because the person also suffers from maybe a disease like diabetes, lowers his immunity, and he succumbs to cancer very fast. That is why the concept of attributable factor. So the attributable factor is talking about to what extent did that so-called exposure factor, what is the contribution of that exposure factor to the development of the disease? That is what the attributable risk measures. So when you simply put by formula, attributable risk is incidence in the exposed minus the incidence in the unexposed. So if the incidence in exposed, for instance, is 80%, right? Disease incidence in those exposed is 80%. It means that when we subtract and the incidence among the unexposed is 20%, when we subtract 20% from 80%, then we have 60%. So that 60% is the attributable factor, or another name for that attributable factor is excess risk. Is the excess risk. It's also called excess risk or attributable factor, which means we are saying that the disease was contributed, which the person developed, in this case, lung cancer, by 60% of exposure. Why do we say so? In this case, example, those who were not exposed, 20% of them still develop that disease, irrespective of the fact that they were not exposed. While those who were both exposed, who are now exposed, 80% of them develop disease. So the excess risk was 60%. Then there's another concept called attributable risk percent. And the formula is there, how you get attributable risk percent. So that attributable risk, if you want to now express it in percentage, you have it clearly for you. Incidence in the exposed minus incidence of the disease unexposed over the incidence of disease in the exposed. And that will give you 75%. So the attributable risk percent is 75%. The attributable risk is 60%, or the excess risk. All right, so those are the concepts. The interpretation is the same thing as we have in case control studies, which means for the exposure factor to have relevance in the development of that disease, it must have to be 1. It must have to be above 1. If it is only 1, then that exposure factor has no relevance in the development of that disease. We are saying that that disease would have still occurred whether the exposure took place or the exposure did not take place. Now, the advantage of cohort study is that we're able to calculate incidence rate. I told you earlier on that disease incidence is, we calculate disease incidence when new cases emerge, new cases of disease emerge. They are called emergent or incident cases. Incident cases. That's where you calculate new cases. Prevalent cases are all cases, both old and new. Prevalent cases, all put together, both old and new. Incident cases are just new cases of the disease. Here, we can calculate new cases because we are following people up over time. And as they develop the disease, as we are following them up, we take note of them, we count them. So the advantage here is that we're able to observe when the diseases develop. Then we can also discover other factors which were not intended ab initio, because we are following people. We could be looking for lung cancer. Now we could be, by the time we are testing them, we are seeing that other things like blood cancer is also developing, right? So that was not our intention. Our focus was on lung cancer, but because we are running tests and all that, so when you do a cohort study looking forward, the possibility of identifying other associated factors can arise. Okay, so because we are able to observe the disease occur, of course, we are able to estimate the relative risk. In the case of cross-sectional study, we could not know when the disease occurred. We only saw the disease and tried to determine the exposure factor that led to that disease. So for that reason, since we did not see the disease occur, we can only guess, right? And that is why we calculate the odds ratio, the probability of occurrence. Now, cohort study can help us establish disease etiology. Disease etiology means disease causation, what caused the disease. Even though that is not in the strict sense of it, but we say, or the natural history of the disease, okay? The natural history of disease is when a disease, assuming somebody is infected with a disease, no action whatsoever is taken, and we just observe to see how the disease develops. That is what we call the natural history of disease. The course which that disease runs without any form of intervention on it. That's the natural history of disease. So here we can observe, we can infer causation or etiology. Why? When the relative risk is very high, then we say that it is most likely the cause of that disease. Here, selection bias is also less likely because we do matching, right? We do matching, we observe, we are following, unlike case control, when it has occurred already, it's more difficult. in selecting by controls. So the disadvantage here is it is time consuming, unlike case control that is less time consuming. So here, unlike also case control, it is very unsuitable for rare diseases because you might follow the people forever. The disease you are looking for will not emerge. So for that reason, when it comes to rare diseases, we identify those that have already emerged and try to look backwards to see what exposure factors that led to their emergence. Remember that this time around, analytical study, we are looking at how and why. That is why we are saying all this. We are not now merely describing what happened. Okay. So, however, a major disadvantage is what we call attrition. Attrition means loss to follow up in diverse ways. People can decide to say that, okay, they can japa, right? They left the study. People, although there are ways we compensate for that, if they leave, we use other people to replace them. People can change their status, right? People can migrate. People can become disgruntled and decide to, every time coming, you people are collecting my blood, I beg, I'm not doing it again, and things like that. So it can happen. Or people's status can change. Maybe somebody who was smoking before decided is no longer smoking. Or somebody who was working in that factory before changes job, right? The person became born again and is no longer smoking. So that's a form of attrition, right? Also, there could be error in classification because of that, or along the line, there could be changes in diagnostic criteria. Science is developing every day. Science is developing every day. Along the line, maybe the method we are using to diagnose a disease has changed. The other time we are doing microscopy for TB, we are doing acid-fast bacilli microscopy. Today we are doing gene expert. Today we are doing TB lamp, right? So diagnostic criteria can change, okay, and can mislead us. There could be administrative problems. We can lose experienced staff. People can poach experienced staff from the organization. You can lose funding, just as Donald Trump came say, hey, no, USAID enough. You have been doing Father Christmas. No, enough is enough. You can lose funding. And again, because we are fooling people over time, record keeping can be high cost. Okay, so that is that. Then the other aspect that concludes this one for me is the one we call historical cohort or retrospective cohort. Retrospective cohort, just as the word suggests, is also a cohort study. If you watch the difference between cohort study and case control study, you see that in cohort study, let's start with case control studies, we started from the disease. We've seen the disease, and we are going back to look at the exposure factors that probably had led to that disease. On the other hand, for cohort studies, we do not have the disease. We do not know what will emerge. What we know is the exposure factors, and we are now following over in the future to observe to see which disease will emerge. So you can see the difference. So historical cohort or retrospective cohort is the same thing as cohort, which means we, as at today, we do not know the disease yet, but we want to determine, what we know is the exposure. Having known the exposure, we want to determine the disease. So we can tweak it this way. Instead of following people for, say, 20 years, to observe what happens. Can we look at people who have been exposed for the past 20 years instead of following them, watching for 20 years, which is very laborious? Can we see if we can identify those who have been exposed for 20 years instead and examine those ones who have been exposed for 20 years and see what diseases they have now? You see, instead of say, okay, let's follow this group of people, group of students for 20 years to see whether those of them, assuming those who want to see the effect of smoking or any other exposure, hard drugs or any other, or alcohol, excessive alcohol, and following them. Maybe we don't have time to follow them for 20 years or 10 years. We decided to look back into history by instead selecting people who are exposed to those factors already we know of in the past 10 or 20 years and go and examine them now. And when we examine them now, we discover changes. So from the example I gave to you, assuming we have two groups of nurses, one group who have been smoking for the past 10 years. The other group are not smokers. So we have matched these two groups, right? They work in the same hospital, earn about the same salary, about the same age. The only difference is that one group are smokers, the other group are non-smokers. So we have identified them. Then we have in mind what we are looking for. So we decided now to examine them, the two groups, examine their chest, examine, do their MRI, CT scan, every test we want to run on them to identify if they have any respiratory, do their lung function test. We do their lung function test and compare their lung function test. Then we might now see that, the lung function test of those who have been smoking for 10 years or 20 years is far more, far poorer compared to the lung function test of it. So we'll calculate the relative risk. Maybe we will say those who have a lower, assuming what we're looking at is low respiratory volume or vital capacity of the lungs. Yeah. So we'll say which proportion has low vital capacity among those exposed to smoking and those low vital capacity among those not exposed. We also calculate the relative risk. Why? Because we have just discovered that now. That makes it a cohort. Even though we looked back in history over time what they have been doing. So that is the difference. So here it is, the evidence is historical. The exposure is historical. That is what we call it retrospective. We got them, they were smoking, information that they were smoking in the past. But we have now examined them to identify the relative risk for those exposed and unexposed. And we use the same formula and every other thing is the same. I believe it's clear to you, okay? All right. So, okay, here I also made it a bit clear. A retrospective cohort study tries to compare the risk of developing a disease to some already known exposure factor that occurred in the past. A case control will try to determine the possible exposure risk factor after a known disease incident or a disease has developed. All right, so now let's go to experimental studies. Experimental studies are known to be the gold standard. The gold standard in original research. Okay. experimental study. Please listen to me. I'm sure your question now has been asked. Listen carefully and try to follow. Try to understand. Try to understand attentively. It's not difficult. There's no combination there. Understand it. Once you understand it from first principles, then you won't have problem. But when you don't listen attentively, you'll be asking me plenty of questions until I'm confused. All right, experimental studies are considered the gold standard. We use experimental studies for several reasons. Okay, we use it to identify the usefulness of an intervention. You use it for in clinic, so you have randomized clinical trials, which most of us are familiar with or heard about. Maybe you want to see if one particular drug is superior to another in controlling a disease, maybe arthritis, or maybe even cure rate. If you check, research is going on every time, even in the pharmaceutical industry, everywhere, biochemistry everywhere. New drugs are being made. Look at multi-drug resistant TB. In the past, say 5-7 years, okay, about that. Even in our own hospital, we had the clinic in my department. When we started, we were hosting a national center. When we started, the drug that were being used, the treatment hospitalization was for a year and a half, 18 months hospitalization. And for all those period, the people are masked. So you can imagine a situation you are putting on mask for 18 months. 18 months. Even if you are sleeping, you have mask. It's a terrible experience. All right? Even we, the clinicians, we have too much pity on the people. So social life is worse than prison. They can't interact, they can't do anything. Confined to their ward, hostel, right? But today things have changed. It has been reduced to 6 months, from 18 months to 6 months, because of newer drugs, more efficacious drug. For us to now change the policy, there must be strong evidence that this new drug is better than the old one, or it is safer. And before we start, we have to do both kidney function test, liver function test, the hearing, everything, auditory functions, because of the side effects of those drugs. Those drugs were toxic. At times, it knocks off hearing, being hearing loss. We begin to run to ENT surgeons to come for consultation because our patient cannot hear again because of side effects. So, but today, all that have changed. Newer drugs are now there. Okay? So, how do we implement this newer drug, bring it and change the policy? It's through studies like this, clinical trials. We'll try the drugs. So, a situation we have two drugs, A and B. A is the standard care. That's the one we are using. So, we want to look at either equivalence trial or superiority trial. We want to see if drug B we have just made is equivalent to drug A, which is the standard care we have been using, or if it is better in terms of efficacy, right? So when we want to do that, we identify two groups of patients. Before now, you can read some books, you see, you hear about placebo. Placebo is not an active drug. Maybe it's just made up of talc, zinc oxide, right? It's harmless, okay? Or maybe coated activated charcoal. It cannot cause harm. But in clinical setting, you cannot, because you want to conduct experiment, unnecessarily expose somebody to harm by giving the person a drug that is not an active ingredient. It's ethically wrong. Okay, it's ethically wrong. Okay, let me not skip this before I go further with the nitty-gritty of experimental studies. So here are the types of experimental studies. The randomized controlled trial, which is the highest of them, followed by the non-randomized controlled trial, non-randomized trials, or quasi-experimental studies. Then we have the community trials. We have field trials, okay? So all of these are experimental studies, all of them, right? Experimental studies. So going into the steps, we have identified we are given to test two drugs. One is coated yellow, one is coated green. The standard one we were using before, we do not know, but they coated it yellow and gave it to us this time. And another one, which is a new one. So they have just asked us to try these two drugs, yellow and green, right? And they didn't give us much information on the two. Let's try them on our patients. Maybe our patients will want to show the length of pain control for somebody suffering from arthritis. Maybe one can reduce pain and sustain pain reduction for 1 month. The other one, maybe that's the standard one we are using. And the other one can sustain pain reduction for 6 months. Right? So we want to try both, yellow and green. So the company that gave us this thing, the job to do, has made the drugs. He has not told us what is yellow. He has not told us what is green. He only want to see which of these. All he knows that both of them are killers. But let's see which of them can sustain pain relief for a longer period of time. So we have set out to carry out this experiment. Our reference population is all people who are suffering from arthritis, because that is the population we are going to generalize our study on. Okay, so now we've sought for their consent. The ethical issues in experimental study is very stringent. So those who agree to participate, we call them participants. Those who say they are not participating, no, they don't want to be part of it, we exclude them outright. Okay, so among the participants now, those who consented to participate, we assign them into two groups. One group, right, will receive the yellow. The other group will receive the green, right? We are not giving placebo, okay? We will receive green. One group will receive yellow, which is the active drug. One group will receive green, which is the new drug. As I said, it's unethical to give placebo, okay? Now, the physician will not, the participants only know that they are taking, one group is taking yellow, one group is taking green. But what is in that yellow, what is in the green, the participants don't know. That is called single blinding. Who did we blind? The participants, the patients. They do not know whether they are taking the new drug or the old drug. They do not know. And there are reasons for all. Then that is called single blinding. Then the other person that does not know is the physician who is administering this drug to the patients as they come for their drug refill or for, to the hospital. Now, the physician also knows yellow and green. He does not know what is in them. He only knows that this group of patients is the yellow group. Whenever they come, I'll be giving them yellow. This green group, whenever they come, I'll be giving them green. Okay? So they keep on coming and is administering this drug. Then after 1 year, after 2 years, and the data was just being collected about we begin to interview them over time to understand about their pain relief, their complaint about things like that, through questionnaire or whatever. We keep on collecting data from them. Then finally, we move all our data to the data analyst to analyze the data. And the data analyst knows yellow and green. He does not know what is in yellow, what is in green. So he analyzes the data, and we saw that green, the average period of pain relief in green is maybe 3 months. An average period of pain relief among those with yellow is 1 month or 3 weeks, right? So it comes up after the analysis. We have seen it. Now, it's time to break the seal. We go back to the manufacturer who gave us those drugs and say, okay, look at the drug you gave us. Yellow can sustain pain relief for 3 weeks to 1 month. Green can sustain pain relief for 3 months or to 3.5 months. Now, in terms of side effects, 70% of people with yellow had complaints of headache or fatigue or a bit restless or sleepless at night. For the same symptoms, 5% or 10% of people who took green like that. So based on this, we can now break the seal. We can now see that green is superior to yellow, right? The way it works. So this is this schematic diagram here. The population of those who have the disease, those who decided not to participate are excluded. Those who decided to participate are randomized into treatment group or either treatment A or treatment B, because no treatment, as I said, is not. And you follow them over time. Okay? You follow them over time and see. So this is general, maybe development of disease or no disease or cure, things like that. So you follow them. That is the beginning. That's the thing. So when you blind the patients alone, it's called single blinding. When you blind the doctor, the investigator, is double blinding. When you blind the data analyst, it's called triple blinding. So you can see in studies, say double blinded studies, it means that the patients did not know which group they belong, the physician did not know which. There are reasons and benefit for blinding, which means that if you don't blind people, the studies could be biased, most likely to be biased. First and foremost, when people who have been suffering from arthritic pain know that a new drug has come, almost all of them will opt to use that, to try that new one. Almost all of them. It's just natural. And when all of them opt for that one, which other one will you now use to compare? So That is one. Those who are who want to please, can you please listen and stop asking certain questions that don't listen? You see, those who know that it's a new drug, of course, everybody will want to try the new drug. That is one. Two, you know that it's a new drug, you are most likely to comply with all the instructions. And that could also bias the study. While the other one, if they know that it's an old drug, I beg, now this will they drink some days, they will drink some that they will not drink. That could be a bias. Again, if even if the new drug is not working well, those who are taking it are less likely to ask for additional drugs on their own. Okay, are less likely to, or they are less likely to leave the study in attrition. In terms of the investigator, you, the doctor, for instance, when you observe one of the person in the new drug feeling somehow, it is you first that will say, I beg, let me not say I'm doing an experiment. This woman died for my hand. You just give additional treatment. You have scattered the study. Okay, or you see the way you adjust the dose. You have also, or you see the way you just say, Madam, me no go good. You withdraw the person completely. You have biased the study. So that is why blinding is important. That is why also this is the gold standard. This is the gold standard. All right. Sorry, let somebody's mind. Okay. So that is why it's the gold standard in research. So that is that. If you want to measure the outcome, there are objective or subjective ways, either through measurement, questionnaires, and all that. Because some of them, to measure the outcome, you are collecting the blood pressure, you are sampling the blood and things like that, urine, conducting tests, depending on the disease. Okay? Yeah. Okay, then the other example is quasi-experimental study. These things are very straightforward and simple, and I think you should be 1 minute, please. All right, quasi-experimental study. Well, quasi or quasi is just a near experiment. It's not an absolute one. Here, the difference is one, there is no randomization. There is no randomization. Unlike the other one, randomized. The randomization means a lot to us in public health or in research, not public health, in research generally, because in randomization, everyone is given an opportunity to belong to whichever group. It's one of the easiest ways to eliminate bias is randomization. So randomization ensures that everybody has equal chance opportunity. So belonging to a particular group is strictly by chance, not by choice. But in quasi-experimental study, you can do purposive allocation. That is, you say these people will be the intervention group, these people will be the control group. You can choose it yourself, right? The investigator can choose where. So like the example here, two schools, secondary school can be the intervention group where you want to carry out your intervention. School B is the control group where you are not going to carry out the intervention. All right. So when you look at those two, you have chosen. Now, let us look at which intervention do you want to carry out. Let's say we want to do sexuality education in school A, and we want to see the effect of sexuality education. We want to see the effect of sexuality education on sexual practices of adolescents. Now, we want to see whether sexuality education is beneficial or not. Because many times education or knowledge does not always translate to practice. Right? Yeah, people know that smoking is bad, yet they are smoking. So we want to see. Now you decided to do this education in school A and don't do it in school B. But before you commence your intervention, just 1 minute, please. Let me ease myself a bit. All right. Sorry, I'm back. I've been around since, but maybe somebody logged in and walked away. So we couldn't. I've been sending this thing to. Okay. So in situation, we have two schools. One is the intervention or experiment group school. The other one is control. So what we do in such instances, we first and foremost carry out a baseline study. We use one instrument, administer it, say about sexuality education, their understanding and their practice in both schools at baseline before the intervention. Baseline before the intervention. If we administer it in school A, administer the same, we observe the knowledge and the practice of the students, of the children in school A and in school B at baseline, which means before the intervention. We compare what they know and what they practice. Because they are identical schools, we might discover, most likely discover that what they practice is similar because no intervention has taken place. So when we compare the two at baseline before the intervention, we will see similarities between school A and school B. Then by our protocol, we decided to carry out the intervention in school A. We implement sexuality education for 2 weeks or 3 weeks. And we do not carry out similar intervention in school B. And we wait after 6 months. We use the same instrument we used at baseline to now try to know if there's any change in school A or in school B. So in school A, where we carried out intervention, we probably will see a change in knowledge or a change and practice, right? A change in knowledge of safe sex or whatever in school A where we practice. In school B where we did not make any intervention, we might discover that no change has taken place. what we found at baseline before the intervention still remains, right? Then we can say that the intervention we carried out was responsible for the change that took place in the arm in the school A where we carried out intervention. Why do we say so? We can infer, or we say so because the school B where we did not carry out any intervention, there was no change. What obtained initially 6 months ago at baseline, when we compare results today and the result 6 months previously prior, that is at baseline, are the same, similar, no change. But in school A, where we carried out the intervention, if we compare the results today and the result previously, we observe a change has occurred, right? So in that, guys, we attribute the change that occurred to the intervention. That maybe that intervention is a beneficial intervention because it caused a change. That change we see is the effect of that intervention. Is the effect of that intervention. So that is in a skeleton, a simplified explanation of what a quasi-experimental study is. First, you measure baseline at both schools, compare both of them. Make sure that they are comparable. Because I often said, you cannot, if both of them are not comparable at baseline, any change thereafter will be difficult to be attributed to that intervention. For instance, if school A had better knowledge compared to school B at baseline, and after the intervention, school A still had better knowledge, you won't know whether the intervention caused the better knowledge. You can only say, okay, there's an improvement in the knowledge. And it's difficult even for you to say there's an improvement in that knowledge. Why? Because you don't know whether that factor that was responsible first for the improvement, for better knowledge in that school, still contributed to further improvement in that school. So one of the things you must take note at quasi-experimental study is that at baseline, the two arms must be similar. If the two arms are not similar, it's difficult to prove. But once the two arms are similar, then you carry out the intervention in one arm, and about 6 months or a year later, you use the same instrument, not different instrument. Because if you use a different instrument, it's a different ball game altogether. You are doing a different measurement. You use exactly the same instrument you use at baseline and repeat it there to see the difference. If a difference has taken place in the intervention group compared to the non-intervention or control group, then you attribute that change to that intervention. Having done that, then you can now come back for ethical reasons to now implement that intervention also in school B, so that it doesn't seem that they are just used for experiment as guinea pigs, right? For ethical reasons, okay? So that you now, as compensation. But if maybe it is such an intervention that, oh, for whatever reason it's too expensive, you cannot carry them, maybe you do any little thing for them as like some sort of compensation for their time and, and their participation, right? So that is that's quasi-experimental study for you. Field trials, we use it more for vaccine trials, okay? Now, if we is similar to randomized trial, controlled trial, but not exactly. In this instance, we made a vaccine, and we all know that what vaccine does is to protect people from infection. Now, we look at two communities, two areas where we want to try the vaccine to see how protective. We want to find out what we call the protective factor of that vaccine. So we vaccinate children in community A, and we do not vaccinate children in community B. After which, vaccine is done against diseases. We go to determine incidence of disease in the community where we vaccinated children and the incidence of disease in the community where we do not vaccinate children. Now, if the incidence of the disease, as is presented here by that formula, we calculate the efficacy, vaccine efficacy, or another way we call it, if you don't call it vaccine efficacy, you can call it protective factor of the vaccine, right? So, incidence in the exposed, subtract from the incidence in the unexposed, 0. Incidence I 0, unexposed. So incidence of the disease in the exposed and incidence of disease in the community that had vaccine, they are exposed to vaccine. Incidence of disease unexposed, they are not exposed to vaccine. So naturally, we expect the incidence of disease in that community where children were not exposed to vaccine. So you use that simple formula and you calculate the. So if the incidence of disease among those exposed is 4.7 per thousand or 47 per 10,000, incidence among those unvaccinated is 16.8 per thousand or 168 per thousand. You can calculate the vaccine efficacy, right? Incidence in the unexposed minus the incidence in the exposed over the incidence unexposed. You have 0.72 or 72%. All right, so the vaccine efficacy is 72%. And this means that of all the people vaccinated, all the children vaccinated, the vaccine was able to protect 72% of them. That is fair, vaccine is able to protect 72, which means the vaccine did not protect everybody. The vaccine did not protect 100%. That vaccine was able to protect 72 of every 100 that took it, right? So that's vaccine trial or vaccine, efficacy trial. Community trial is also simple. Here, I just use a small example. You can randomize communities, right, into two, and maybe allocate health facility in one and health facility and no health facility in the other one. And after a while, you try to look at, because you want to see the relevance or the importance of locating healthcare facility in a place. Because if you do that, the chances are that people in those places will make use of them. And when they make use of it, disease mortality and all that declines. So you can just use that. So the disadvantages of experimental studies that they are costly, they're expensive. They might have, very significant ethical issues. And that is why the protocol for experimental studies, randomized control trial, are very strict. Not all conditions also can be, can be experimented with, not every condition. That is why there is quasi-experimental. There are some it's not possible to do experiments, so you do a quasi. They might require a long follow-up, just like cohorts, Then attrition or loss to follow-up might be also a problem. They might be highly technical to conduct. So these are the disadvantages. All right, that is that. Let me stop sharing this and okay, let me leave it. Let me just stop sharing it and try and look at the next lecture with which um, bias and confounding in epidemiological studies. It should have been bias and confounding in research. It's not really epidemiological studies. Epidemiological studies are just one of the way we say research anyways, studies, research. Okay. Please. All right. Errors can occur in research, and they do occur in all studies. No study is completely error-free or perfect. However, every effort must be made to minimize errors because it has a lot of implication. If anybody tells you you are going to London, that this plane has a 10% chance of crashing, you probably will not even enter, because of the magnitude of that, the chances of the error that can occur. So error can be estimated. Error is the difference between an estimated or measured value and the true value. But the interesting thing is that the true value is not known. Nobody knows what the true value is. In science, what we know is facts, not truth. It's only God that knows the truth. There's a difference between truth and fact. Only God knows truth. All right? Facts are things we can experiment on, we can touch, we can feel, we can do this. So is that facts? But truth, we might not know the truth. So in science, we can know the facts because it's the evidence before us. That's what we can say about it. So important questions about errors we ask is that, to what extent does a test accurately measures what it purports to measure? To what extent? So these are valid questions, When we say accuracy or validity, how much a test measures what it's supposed to test, right? When you say test is valid, we are saying that it accurately measures what it tells us it measures. Now, at times, it is very difficult, but what we strive to do is that we try to get closest to the truth, which we do not know, as much as possible. That is, we are striving for perfection, but we don't know whether we got there or not. So, ability of any test to distinguish or separate those who have the disease and those who do not have the disease. A disease is very important. So it's very, very important. Now, unfortunately, some errors can occur. So all errors have been grouped into two: random error or systematic error. Random error is the error that occurs by chance and it's not as dangerous. It can occur by chance. But the one that is completely unacceptable, which to us in research is the one we call systematic error, and that is what we call bias. Once a systematic error occurs, the study has been rendered useless. Once a systematic error occurs, this study has been rendered useless. So it is our responsibility to make sure that there is no systematic error. So what are the sources of error? One, there could be individual biological variation, because as we know, no two persons are perfectly matched as the same. Even identical twins have genetic differences, right? Now, the other one is sampling error. It occurs when the sample size of a study is small. A sampling error can occur when the sample size is small. It can also occur when you don't use what we call the probability method in sampling. Maybe when you are doing sampling, you are doing multi-stage sampling or cluster sampling. In those cases, all the people have not been given equal opportunity in that study. So a sampling error occurs when equal opportunity is not given to everybody. So to compensate for that, that is why we calculate a design effect. The design effect is to compensate for sampling error. And the way we achieve it, we will multiply that sample size by 2. Multiply that sample size by 2. Then another thing that can occur is measurement error. When, for instance, the research protocol is not very clear, when your measuring equipment are not calibrated, you measure blood pressure for the same person 2 times, it's giving you different reading. Then you know that equipment failure, equipment calibration can be the problem. It can introduce errors in your study. Right? So how do we spot errors in research studies? The best approach to spot error and bias, the best approach is to be skeptical about every study you are doing or you are reading. Never believe that they are perfect. Whether you are the one conducting it or the one you are not conducting it, just be skeptical. When you are skeptical, your level of alertness about the possibility of error is high. But when you are complacent, errors can creep in unknowingly to you, because you might have a sense of false belief that you are doing the best, but actually there are errors. So before this quote, before a scientist sets out to convince others of his observations or opinions, a scientist must first convince himself. Let this not be too easily achieved. That is why you must be skeptical. It is better by far to have the reputation for being querulous and unwilling to be convinced than to give reasons to be thought gullible. It is better you are unwilling, you are always suspecting that something would have gone wrong, something could go wrong, than to just, believe that you have done the best. Okay, so that's how it works. The only way to absolutely identify an error is to know the true estimates, which I said truth cannot be known. Everything we are measuring are estimates. They are not absolute. We don't know. So how do we remove errors in studies? We start with the design. Study design is the most important decision to take. When we look at the slide on hierarchy of research studies, I told you the other day that the study design is what determines the hierarchy. Study design determines the strength of evidence produced, the output of any research, right? Whether it is low, weak evidence, whether it's moderate evidence or high evidence, is determined by the study design. Each study design has its strengths and weaknesses which must be explored. Data collection must be properly planned. So study design, data collection, important. For data collection to be important, it means that the data instrument, that's your questionnaire, your tools, must be well-validated tools. You do the face validity, content validity, or also construct. Then you do the reliability of that instrument to make sure that they are valid. You calculate the Cronbach's alpha coefficient, right, in the software. If the Cronbach alpha coefficient is more than 0.7, it is good to go because the value ranges from 0 to 1. Anything 0.7 and above, the questionnaire is good. That's why you do questionnaire testing. Some use test-retest method, but the best way is to use a software. That is, if you do that, what you are doing is you are testing for the internal consistency of that questionnaire. For instance, a questionnaire might be useless if you administer it to 3 persons and they give you 3 different responses based on how they understood it. Then that questionnaire has not communicated. So data management has the potentials for human error also. So don't assume. I've seen a lot with what students bring, especially, I'm sorry to say, most of our students try to use contractors because they are probably brain dead, I don't know. They don't have confidence in themselves to do anything. They believe that they either go and recycle one thing or the other, believing we don't know. Well, most times you do not succeed in cheating us, most times. No, because we know. All right. But if you succeed, all well and good, you only succeeded in cheating yourself. You cheated yourself from learning. You could have a certificate, but no knowledge. When the chips are down, you'll be found wanting. Period. There are no two ways. Data analysis also poses a threat, can be used to reduce the effect of errors. It poses a threat, but we can also use it to reduce, we can use it to clean out errors and all that in data analysis. So if we want to improve accuracy or precision of our study, there are many things we do, right? We want to first and foremost ensure that our objectives are clearly defined and measurable. I always tell students, any objective you cannot measure, throw it away. Because what you cannot measure, you cannot prove. This science is about evidence, data. numbers, it's evidence. Once you cannot measure it, you can't prove it, it is useless. Prepare your study protocol with clear objectives for tracking errors. Precision is a lack of random error, right? Precision, random error, that's chance. So if for your work to be precise, there should be no error. There are many ways we try to make our work precise. If you ever heard about 95% confidence level and things like that, it must not be 95%. We are only saying that any error to that study is to the extent of 5%. You are 95% confident that the results are valid, but we can go more than 95% and go up to 99%. But it has implication. The implication is that the sample size will be very high too. So reducing precision reduces a type of error. So precision is largely determined by the sample size. The higher the sample size, the higher the level of precision. Okay, accuracy, validity is a lack of systematic error, lack of bias. Once there is no bias, then the chances of accuracy is high. Internal validity. For a study to have internal validity, it means that the study must have been properly done, starting from the design, the clearly stated objectives, well-designed instruments, well clearly identified data collection procedure, right? And good data analysis. If this is done, then that study can be said to be internally valid, internal validity, okay? Because it will be close to the truth, even though we don't know where the truth is. Then for a study to be externally valid, it means that the results can be generalized, can be generalizable, right? Then before conducting a study, you need to ensure that there is no random error or there is no bias or confounding. Confounding is the next one. I told you about bias, which is a systematic error. The other new term here is confounding factors. As we go, I'll let you know what confounding factors are. Okay, this is an example of generalizability or not. You see, this does not necessarily mean that the findings, okay, let's generalize to other circumstances. Sorry, let me follow it here. However, internal validity must be established before one can consider whether the results are externally valid. Therefore, investigators must first ensure that a study is internally valid. And if that means the generalizability of the study will be compromised, even if that means the generalizability will be compromised, first and foremost, the most important thing is to make sure that the study has internal validity. Whether it will be generalizable or not is a second ball game or next. Let it be, first internally valid, which means all the good steps to conduct a good study is followed or are followed. In contrast to random error, I told you random error is chance, anything that occurs as a result of chance. Okay, bias refers to systematic error. In any type of study that results in in any type of study that results in an incorrect estimate of the association between exposure and outcome. So whenever a study is biased, it gives an inaccurate estimation between exposure and outcome. An inaccurate estimation between exposure and outcome. You can find this when you talk about alpha error and beta error. Alpha error and beta error. I believe after now, okay, maybe you have studied statistics, I'm sure. Maybe Abia would have mentioned something like that to you. Okay, immediately there's inaccurate estimation. Okay, then it can lead to that. Investigators can introduce bias into the study as a result of the procedures of identifying and enrolling subjects. See, you can have bias can come in different ways. It can also be introduced by the classification of exposures or outcome. It's a systematic error. It can come in different ways. So yours is to make sure there is no bias by making sure your study is accurate. Now, a study with a small bias is said to have high accuracy. Accuracy is not affected by sample size, okay? Accuracy is not affected by sample size. Now, there are types of bias. One is selection bias. There are many types of them, but they are grouped. There are common ones we use: selection bias, information bias, and okay. Here in selection bias, if there are differences in which in a study people are selected, like in analytical studies, when you are selecting intervention and control groups, and you do not do it well, you have introduced bias in the study. You cannot select males in one arm and select females in another. So you must be very, you cannot select educated people in one arm and uneducated people in one arm. Okay, you cannot people with high socioeconomic status in one, those in low socioeconomic status, no. The other one is information bias. Information bias also can occur, right? There are many ways information bias can occur. When, for instance, people are giving information, things like subject desirability bias is an example of information bias. Maybe people tell you what you want to hear because they perceive either they can be penalized or they are doing you a favor. They have not expressed it accurately the way it is. They want to tell you what you love to hear. That's subject desirability bias. Then it can also happen that people might forget exactly what transpired if a long time ago, right? That can also be an information bias, though we call it recall bias. What are you recalling? Information. It will affect the study because you could not exactly remember what, or a deliberate attempt to distort information. can also, all of those are information bias. Volunteer bias can occur is as part of selection bias, right? So we group two of them as selection bias and information bias. So let's deal with selection bias first. Now, volunteer bias as part of selection bias. If you are doing a study about, you want to see effect of smoke on health, a lot of people who are smokers might volunteer to be part of the study. Why? Because they know their condition. They are either worried or concerned that they might have adverse health effects, so they volunteer. And that can bias the study, right? So they will more likely to volunteer than those who are not smokers, right? Now, there is also non-response bias, whereby individuals do not respond to maybe either mailed questionnaire or whatever. They do not simply respond. Okay. For instance, smokers are less likely to return your questionnaire than non-smokers. When you ask them question about smoking status, they might just wish it away and don't answer you as you leave them alone. Exclusion bias. This can occur when certain studies exclude some participants. Okay. When exclusion criteria is different from the cases, exclusion criteria. Many times, people find it difficult to understand inclusion and exclusion criteria. Okay, but we try our best to teach people to try to understand it. Healthy worker effect, that can also another form of bias. Those who are healthy workers usually remain in them, compared to those who are not healthy. Healthy people remain workers, whereas those who remain unemployed, retired, disabled, or otherwise out of active work population are a group of people who are less healthy. So now, when you are going to carry out a study among people, workers, and it has to do something about their health and all that, you just know that the people you are carrying this study out on are already known to be healthy. That is why they are working in the first place. Because those who are not healthy are usually screened off during medical examination and all that. Or when they get very sick all the time, they retire them and give them disability allowance to go and rest. So when you carry out such studies and you make conclusions that, these is healthy, know that those people have been selected already to be in that category. So the healthy worker effect is usually a special type of selection bias that occurs in a cohort of studies of occupational exclusion when the general population is used as a comparison group. So you can never use the general population because they are not the same already. Information bias, I mentioned, it can cause a lot of problem for us, information bias. Either people are telling you what you want to hear, or people forget. Examples: interviewer bias, recall bias. People simply don't remember. Interviewer bias about information. There are ways you ask people questions, they know that you want them to say, they know what you want them to say, and they give it to you that way. Then reporting bias. Participants can collaborate with researchers and give answers in the direction they perceive are of interest. That is desirability bias. Pattern effect. Pattern effect is when people behave differently when they know that they are being watched. If people know that there are supervisors observing their practice at work, you see them all very serious working. But if they know that nobody is watching them, be their usual self, and they know they are working hard. So the example about a factory is there. Then lost to follow up. Those that are lost to follow up or who withdraw from a study may be different from those who followed to the entire study, right? Surveillance bias. There are several groups. The group with known exposures or outcome may be followed more. If we know that somebody is a smoker and our hypothesis is that smokers usually are more likely to have lung disease, we will examine the person's lung, even if we are not seeing anything, as if we're insisting on seeing something. Why? Because we know that that person is a smoker. We will examine the person's lung far more than we'll examine the one who is not a smoker. That is surveillance bias. We already biased the study by over-examining somebody. Now, confounding, because when you over-examine, you will find out something that is not even intended. Confounding is a different situation altogether. It's a situation in which a measure of the effect of an exposure on risk is distorted because of the association of the exposure with other factors that influenced outcome under study. Well, in case you don't understand grammar, it's simply saying that if a study is confounded, there is a distortion between the relationship of that exposure, right, and the outcome. Let me explain it by example. Take, for instance, you want to see the effect of smoking on cardiovascular disease, or you want to see rather the effect of sedentary lifestyle when somebody is not taking part in exercises and all that, always stay in one place. You want to see the effect on cardiovascular disease or obesity. If you want to see the effect of sedentary lifestyle on cardiovascular disease, then aged people, elders, should not be included in the study. If you include elders in that study is already biased. Why? One, you know that elderly people, because of their age, they are already weak and do not move again. So their sedentary lifestyle might be as a result of age. The second thing is that as people grow old, cardiovascular diseases emerge with aging. So if you bring elderly people, you will not know whether it is the sedentary lifestyle is causing the cardiovascular diseases or just the natural aging process that is causing the cardiovascular disease. So in that case, age is a confounding factor or a confounder in that study because it will distort the relationship between the sedentary lifestyle and cardiovascular disease. Age will distort that relationship. So those examples are clearly given. When another exposure exists in the study population, that's the confounder, besides the one being studied, and it's associated with both the disease and the exposure being studied. So these are the conditions for confounders, to be a confounding factor. The risk factor of the disease must exist independently, right? For instance, age is a risk factor. It exists associated with exposure under study. It is not causal. So this is the diagram that shows, for instance, now, if you want to see the effect of smoking on heart diseases, people who are coffee drinkers, or if you want to see the other way, if you want to see the effect of coffee drinking on heart disease, because coffee contains a lot of caffeine on heart disease, then smokers should be excluded. Why? Because most smokers are more likely to be coffee drinkers, or coffee drinkers are more likely to be smokers. So if you don't remove smokers, smoking on its own has effect independently on cardiovascular diseases. So now you don't know whether the coffee drinking, which you think has relationship with cardiovascular disease, is the cause of the cardiovascular disease, or the people who are smokers who are in that study, where smoking independently also has effect on cardiovascular disease. So if you want to do such study, all you need to do is to remove smokers, because smokers can confound it. Okay, this is the one I said about physical inactivity or sedentary lifestyle. Age. So older people exercise less, known. So if you now want to see the effect of exercise or physical inactivity on age, then if you put elderly people, already they are exercising less. At the same time, they are aging, so you won't know which is it. So that is why confounding is like that. However, when we find confounding is fact in studies, there are ways we eliminate them or reduce them. One is by restriction, two is by matching, then randomization. This is at the design stage. When we are doing the study design stage, if we know that, assuming we are looking at coffee drinking and cardiovascular disease, then we make sure we restrict the study to only coffee drinkers. We make sure smokers are not there. So at the design stage, we'll do restriction. Or other times, if we know we are going to find confounders, we do matching. Age for age, sex for sex, socioeconomic status for socioeconomic status, so that the control and the intervention group will be exactly the same, to avoid selection, bias, so let there be no distortion. Another way is by randomization. Randomization is by chance, so that when we do randomization, it eliminates confounders. It distributes them everywhere. In the control group, you find them. In the intervention group, you find them. It distributes it across the board. So there is no particular order with which is taken. Then at analysis stage, we do stratification. Maybe you stratify age, you stratify by sex, you stratify by occupation, like that. You can use that to reduce confounding. Or multivariate analysis. Multivariate analysis in the maybe softwares like WinPeppy, SPSS, EpiInfo, Starter will do multivariate analysis. That's the commonest way we use. The rest are a bit more difficult to use. The easiest one is multivariate analysis. We just put in the software, just run the program, and that's it. So this is how you do restriction. This is how you do matching. You read it, you see. One way to limit confounding is to restrict the study participant to person with certain characteristics. As I told you, like the one in coffee, only coffee drinkers won't bring other ones. You know. Then matching. You do matching so that you get exactly what you want. Randomization, is by chance. Then stratification, you stratify. Multivariate analysis, you put all the confounders in the model and eliminate any association. All right, that's where we end today. There could be something else, but I'm tired from work. Okay, let me answer your questions, please. I believe you would have read it, but there are some questions some of you are asking. I just get discouraged because I thought that when I even give you 1 or 2 days, you can read it. But I can understand you are so busy, so I just ask a few questions. The rest, go and read it. When you read it, maybe your question will be answered. I've given you books. I believe your course rep would have given to all of you, but it's not, I cannot kill myself. I've tried as I can. All right, Wani Ayuba. Okay, hold on. Let me unmute. All right, unmute yourself, please. You can unmute yourself now.
Hello, sir. Good evening, sir.
Yeah, please just be fast so that in the next latest.
Okay, sir. I want to ask about this field trial, that trying of vaccine. That things it makes my sister to be blind. That they tested the drugs on her, and that caused her to be blind.
Which drug was tested on her?
They tested, I don't know the type of drugs they tested on her, that they want to test it when she's having an eye problem.
Then since you don't know, you cannot say it's her hand. You know whether your sister would have still been blind without it. You don't know whether it's drug now. Because if she has eye problem, maybe it's a drug they put in the eye.
Okay.
Is it?
But that time they said they wanted to test that drugs on them. But luckily enough, she's the only one that have that problem. She's become blind.
Well, sorry, I don't know about it. It's difficult for me to actually say. And you too, it's difficult for you to conclude because you appear not to have all the facts. So, but she must have a problem before she went there, I believe.
Sir.
All right.
Yes, sir.
All right. Next person, Chiwendu Emmanuel. Unmute yourself and ask your question, please.
Okay, Prof. Good evening, sir.
Good evening.
Good evening, sir.
Good evening.
Prof,
Go on,
you
please.
said that sample size does not affect bias. But before this, when we're talking about bias, yes, you say sample does not affect bias. But you say the higher the sample size, the better the study.
Accuracy. There are two different things. So, accuracy. Bias and accuracy are different. Bias is a distortion. It's a distortion in the study. For instance, you didn't ask the question well, and they are answering it differently. So whether the sample is high or large or small, they are answering it differently. So the sample size matters nothing. But when it's in terms of accuracy of the study, the larger the sample size, the better in terms of accuracy. Because you know that the reason why you do even sample in the first place is that you do not have all the opportunity in terms of either the money or all the resources or all the time to carry out the entire population. So you are selecting a few persons on which, if you carry out that study on that few persons, the result you will obtain will mirror the result even if carried out in the entire population. So the ideal situation is the entire population. But for one reason or the other, we cannot carry it out on the entire population. Then we are carrying it out on a sample, believing that when the outcome from that sample will give us a similar result if we had studied it in the entire population. So the closer that sample is to the entire population, the better. So they are not the same thing.
Thank you, sir.
Yes.
Yes, sir. Prof. Thank you. My question is about the types of compounding. You said
Types
that
of
confounding.
Yeah.
You said that coffee drinkers are more likely to smoke as a type of confounding. Now the question is, if the drinker is drinking only coffee, is coffee drinking only also a risk factor for the disease independently?
Yes.
Okay, thank you.
Yes. When we are saying that coffee drinking, because of caffeine, coffee contains, that's why sometimes you see decaffeinated coffee.
Yes, sir.
Caffeine is not very good for the heart. That is why those people who drink all these energy drinks, bazooka, their name alone is enough to tell you that they are dangerous, fearless, and they contain a lot of caffeine. That's why it is fearless. It has cardiovascular effect. So if you want to see the effect on cardiovascular diseases, for instance, and at the same time, the people who are also contained in that study are smokers as well. Any effect you find becomes difficult to know, to conclude whether it's as a result of smoking or as a result of, some are called monster, predator. Okay, you know them. So that is this thing.
Yes, sir. Thank you, sir.
Yes. All right. The next person is Darlington. Unmute yourself. Darlington, unmute yourself. Then Prince Adegbite.
Yes, Prof. Good evening, sir.
Good evening.
Yes, sir. I just want to find out with regards to retrospective cohort study.
Yes.
For the cohort study, it stated that a time frame of 10 to 35 years. So for retrospective cohort study, is there also a time frame during which this type of studies can be carried out?
It depends on what you want. It's just that something that occurred in the past is not, please, that time frame is relative so that you don't quote me wrong. It can be any time. Let me see, how do you say, in the time of life? Take, for instance, you can follow pregnant women to observe birth outcomes. Is that 35 years? Hello, can you answer now? If you are following women to see the
No,
birth
sir, that cannot be
outcomes.
35 years. That will be
Thank you.
9.
9 months. So what I'm trying to say is that it varies. It depends on the condition that we are looking out for. When you are saying for 35 years or 20 years, it is because for non-communicable disease, it takes a long time to manifest. If it is a communicable diseases, 3 weeks, 1 month, already you begin to see. So those ones you don't need to follow 35 years. So it depends on the disease or outcome we are looking at. That's what determines the length of follow. Is that clear? So there's no specific
Thank you, sir.
time. All right. Obaji Irene. Go ahead.
Good evening. Thank you, Prof. My question is on the random errors.
I can't hear you,
You
please.
gave a solution for sampling error. Hello, can you hear me, sir?
Go ahead.
Can you hear me, sir?
Go ahead. I can hear you, but it was slurring or
Can
something.
you hear me, sir?
Oh,
Okay.
talk now.
Okay.
Talk. I can.
All right, sir. My question is on that random error. My question is on that random errors. You gave a solution for sampling error that when the sampling size is small, you multiply by 2. And then
That's
for
design effect.
measurement errors, you said if it is not calibrated.
Sure.
So that means if the measurement equipment are calibrated, there might be chances
There
of
are many.
okay,
There
but
are
for
many
individual
types of.
biological variations,
Hold
you didn't say
on. Don't misunderstand me. I've gave you slide. You read it. There is not one type of sampling error. An error can come in different ways. So one solution cannot solve all errors. One solution cannot solve all. Errors come from calibration of equipment. So if error come from calibration of equipment, no matter the sample size, it cannot correct the error because it's a systematic error. So what I'm saying now, if sampling error occurs, most sampling error occurs from low or small sample size. Small sample size. But it might also occur from equipment calibration. So that's why I say it's not from one source. But most commonest is small sample size, because when people want to carry out a study, the fear, or because it's laborious to do large, question amount of, so people want the smaller one and all that. But it affects the validity of the result. So if the sample is small, the best way to compensate for that is to multiply by 2, or in worst case scenario, 1.5. That is what we call design effect. You are compensating for the design effect. And what is that design error? You are compensating for that error. That's the sample, for the sampling error that occurred. Take, for instance, when you did not give all persons equal opportunity to be part of the study, a form of error also occurs. So you compensate also by multiplying by 2, design effect. So it's better to have a larger sample size. Not necessarily when there is equipment failure or anything. All right.
Thank you, sir.
Okay. Okay, I think that's all. Okay, let me see. Okay, one hand is still raised. Go ahead. Okay, Nda. Go ahead.
Yes, Prof. Nda. Okay, so I thank you for the lectures. I actually get confused sometimes in respect to choosing these study designs when you have something in mind, for instance. So I would just want to ask a question, so maybe you could just help me. If I want to, for instance, do a study on why Nigeria and other sub-Saharan African countries find it difficult to, benefit directly, immediately from novel drugs, for instance, like maybe those that control diabetes, the Ozempic, and the rest of them. What kind of study will I, undertake to actually find out the reason behind, that delay in these drugs being available in Nigeria as compared to the Western countries where these drugs are actually developed?
Are the drugs cheap? You don't need study now. I did not buy. Did they say they will not sell to you? The reason is that you simply cannot afford it. Maybe you are waiting for donor now. You are waiting for donor to bring it to you at subsidized rate. That's what we have been doing now.
But still, in the society, there are people who actually request for these things. Just like the ones I mentioned, for instance, I've had people who have asked, for it, and where we had to pass through a lot of bottlenecks to get those things brought to Nigeria. So it's not like there are people who can actually afford. Not everybody though. But I have that interest, in trying to know, apart from those who cannot afford on that general scale, other things that could be responsible for these drugs not being available, unless you're saying it's just the cost of the drug that is the main thing, and then maybe I can just let it go.
I think that is the cost of the drug. When you look at our money, you look at this thing. See, maybe most times you see HIV drugs. If they give you the price of that drug, 1/10, 1/20th of the patients cannot afford it. That is why bring global fund and all these funds to, donor funding is a major source of this for African countries. Right. So that's including vaccine. It's not as if we are not spending money. We are spending money, but it's not enough. Our money doesn't have much strength. So look at the HIV. Before we have this highly active, this one we are using now.
The highly active antiretroviral therapy.
No, we're not
TLD.
Yes.
Is it the prevention or the treatment proper?
No.
The first.
This
Is it learn? Is it learn?
No.
If it's the first line treatment, that's the TLD, the dolutegravir based regimen, or if it's a preventive then that's when you talk about the Necapre and the other one.
Dolutegravir. I remember sometime I attended the World AIDS Conference in Durban. I think that was 2016. It was there I discovered that many countries are already using dolutegravir, while in the teaching hospital we are still using nevirapine and this. And they were now reporting how people were feeling very well and how, in fact, several presentations and all that. I was very angry. While in our department, we are, so that's the problem. Take, for instance, now, haven't you asked yourself, Why is it until maybe the last 5 years or thereabout, the test and treat policy came up? What happened? What new? Before now, we cannot test and treat. Your CD4 count must be certain level before drug will be introduced. Why? Because there was no, if you introduce drug for every disease now, it will not go round. It will not go round. So we say, okay, those who are more sick, when they are, we see the CD4 count is above 200 or is above 250 or whatever, then we can begin to give. I've forgotten the exact value. You know, while those people like, imagine people like Magic Johnson, them in the 90s, they had HIV and living very well. And so it's just about the poverty. It's actually not that we can't afford these drugs, so, but it's because that's not our priority. It's not our priority, not that we cannot afford it. Yeah, but it's just not the priority for me. It is when Global Fund and all this now started supporting it. Advanced countries, are they doing Global Fund? It's for poor people now. So
Thank you, sir.
I don't think it's not discrimination or anything. It's cost related. It's cost related. All right, thank you, ladies and gentlemen. We are done. So see you. There are a few more things on the qualitative study that is left on their schedule. Read the slides well and read your books. I gave you books. The other day I didn't give, I've given you books. Read the books, read the slides. You will understand better. It's difficult to understand everything from me. Read the book, read the slides. At least we are giving you a bit. All right. So thank you and good night. If I don't know how I'll look on Dr. Vivian Obona. If you'll be able to do that tomorrow, that will be fine. If not, you will read it up yourself. All right. Thank you. Good night, everyone.